Welcoming you all today to today's scheduled class on endocrinology. And with this introduction, we are coming to the session today. And again, reminding you for your kind information that for maintaining the silence, minimize the noise, we muted all of you. And from before also that those who are new today also, our request that just check your box in the device that there is an option to raise the hand. So whenever you need to ask any question, you will raise the hand. Okay. So in the endocrinology, we are dividing in the sessions as before, and just we divide at, we are telling this is 1A, and come to a first slide of this. You see that this is an observation in all of the medicine book usually there. This is the overall picture of endocrinology in the medicine. So I don't like to discuss more, but when I feel very interested to tell you that whenever you are facing a patient, whatever the system from, the general observation is very, very important. Usually we don't tell it examination. Traditionally, sometimes we are telling that history taking, physical examination, but in between there is one, this is called observation. This is also part of the examination. So in our traditional learning, whenever we talk to a patient in this time, we are observing the patient as well. It is not touching, palpating, or auscultating, only observation. And this observation is of very, very great value. Please don't ignore it. So my request to you, whenever you go through the page in the book, please read observation well and try to understand. Okay. So for all the systems, all the disease actually presented with the informations or problems of multiple systems in the body. You are dealing endocrinology, thyroid disorder, patient presenting with the cardiology. There is the glamour of internal medicine. Okay. So some introduction regarding the endocrine analysis. So this is the principal endocrine axis. Axis word means the plural one. So from master gland up to the target organ, you will find that some hormones are stimulatory, some hormones are inhibitory. So in this picture, many of you know that the italic forms are inhibitory impact over the lower one. So from up to down, it is regulated as such. And very interestingly, this one actually not discussed in our traditional learning. This one you see that the TRH, that means thyrotropin releasing hormone. Thyrotropin means having the positive influence on the TSH. Anyway, this thyrotropin releasing hormone have positive impact on the prolactin secretion from anterior pituitary gland. So we will come across this type of scenario in the coming sessions or your question bundle also. This is one extra information which usually not discussed before. And the second one, alike you see, antidiuretic hormone impact on the ACTH. Usually we know that antidiuretic hormone impact is to retain the water from the distal nephrons. That means distal convoluted tubular distal duct of the kidney. So we know it well, but in between something happened actually. We are not giving more importance over there. ADH have some positive role on ACTH secretion. Then what is the role of ACTH? To retain the salt, right? Adrenocortical hormone. That means there is adrenal gland, especially the zona fasciculata and zona reticularis having influence from the pituitary gland by ACTH. So ADH is pulling the water, ACTH will pull back salts. So it will be helpful for maintaining and balance milieu inside the body fluid or the internal milieu. So other things I think you can understand well. This is the second introduction for investigation, especially the hormonal physiology and feedback system. And if you come to this picture, you may find that the what are actually common diseases presented from each endocrine gland? So from here, thyroid, and it is given up to the ovaries, that means the gonads. These are the main diseases presenting to a doctor from different endocrine glands of the body. So this is the list for you. And if you want, you can make a picture note also, you can make a snapshot also by yourself. And now I like to tell you some principles of endocrine investigations. And many of you know already, you have seen, as we are mature doctor now from junior to seniors, we are giving some advice for endocrine evaluation to do some hormone test. Suppose the ACTH is high, it is coming from the pituitary gland. Now we have to focus the pituitary gland. Is there any anatomical abnormalities there or not? So in this situation, we have to go for the imaging, preferably MRI. Again, if I like to tell about something thyroid gland, hormonal abnormalities are there, clinical presentations are there. So the principle is that we have to do biochemical test first. Try to identify where is the problem, then go for the imaging. Suppose for the adrenal gland, we are facing a patient of high steroid status, means Cushing syndrome. Disease may be in the adrenal gland and disease may be in the pituitary gland. If you don't go for biochemical test, how can we say that the high steroid is coming from the adrenal gland or the pituitary gland? First, if you go through the steroid hormone level as well as the ACTH and other relevant tests, we understand that the high steroid state due to high ACTH means this is the hormone ACTH coming from pituitary gland. Then we can focus by MRI preferably to the pituitary gland. Otherwise, we have to go for the abdominal imaging and we don't find anything, then we are thinking up and go up. It is not a professional approach, not a realistic approach. For that, it is said in the endocrinology, when we evaluate a patient, go for biochemical test first, then go for the imaging. This is one. And sometimes we have to have some biopsy material to confirm the diagnosis, but not very common practice, endocrine biopsy. Okay. In addition, I like to inform you that most of the hormones are very much vulnerable of their secretion in the daytime, nighttime, even exposure to the cold environmental factor. There are variable levels of the hormone in the blood. So we have to standardize the timing of the hormone or some extraordinary approach we have to utilize. These are called dynamic tests. Suppose, very simply, if I like to say you, when we give a glass of glucose drink to the patient, we are giving a challenge to the glucose to the pancreas. Can pancreas secrete insulin or not? So we are interfering the normal physiology of the body by introducing some glucose drink. This is one of the common example of dynamic test. And many occasions in the endocrinology, we have to utilize these dynamic tests. But only possibly that thyroid hormones, usually we are measuring as a random sample. So we have to be cautious about the level of hormones report also in our day-to-day practice, that how it is done before, the proper manner or proper method were utilized or not. Okay. And these are the various pathology, and these are primary gland disease. Sometimes there's non-functioning tumors also in the endocrine gland. This is also another hazard. If we find any endocrine abnormality, we are focusing irrelevantly, we may find some non-functioning tumor in the gland. It happened in the endocrinology. For that also, I am repeating that we have to go for the biochemical test first, then for the imaging. Anyway, we're telling about now the classification of the disease, the pituitary and the hypothalamus. In everywhere also, the rules are same. In the endocrine gland, there are some primary disease, there are some secondary disease. So non-functioning having no impact from the pituitary, hypothalamus to the pituitary. But if it is the anterior pituitary, the superior part, the hypothalamus is influencing there. You know it. Suppose the prolactin is inhibited by prolactin inhibitory factor from the hypothalamus. So there are some releasing factor as well from the hypothalamus. So any gland is diseased, we are telling primary disease. But if the disease is secreting more or less hormone by the influence of other gland, so-called master gland, then it will be a secondary pituitary problem. Like in the gonads also, primary hypogonadism, secondary hypogonadism as such. Anyway, so this is the types of disease in the adrenal gland. And you know that the hormone secretion is excess, hormone secretion is low, but there is some extra issues also in the endocrinology, like other diseases many where hormone resistance. Commonly, they target cell resistance. Hormone levels is normal or high, but there is no functional or phenotypic outcome. So this phenomena is hormone resistance. We can come across few situations, few questions in course of our discussion later on. So with this introduction, I am giving you one question now. Just requesting all of you, you are given 1 minute time. Please go through this question, make your answer in your mind, and then raise your hand. In the next 15 seconds, I will give you some clue as much as I can. Within total 1 minute 15 seconds, you have to be confident with your answer. Then we will go for the discussion. Please go through. And raise your hand, please. May I talk to Dr. Ishrat, please? Can you hear me? Dr. Ishrat?
Assalamu alaikum, sir.
Welcome,
Yes,
sir.
I
Can you
hear
hear?
you.
Okay, thank you. Dr. Farhad
Yes,
is
I do.
ready. Dr. Farhad is ready to answer, please. You can hear from him. Dr. Farhad.
Assalamu
Please.
alaikum. This is impaired glucose tolerance.
Impairs glucose tolerance, that means C. Okay, any other answer from anyone? Yes, please, Dr. Ishrat.
Sir, it is impaired glucose tolerance.
Impaired glucose tolerance. Some clues are given here again. 120 minutes, 2 hours after glucose drink, 10.4. So what is actually the diagnostic level? It is 10.4 or more. Dr. Farhad?
Yes, sir.
What will be the cutoff value of 2 hours after glucose drink to diagnose diabetes or a diagnostic level?
11.1 diabetes.
11.1. Dr. Arifin, please. Dr. Arifin, can you hear?
Yes, sir. Yes,
Please,
sir.
what is your answer?
Sir, that is IGT.
Impaired glucose tolerance. So many of you know.
10 class finishing. Okay. तुम कितने बजे खत्म होता है तुम्हारा क्लास?
So please, now I'm giving you the answer and description. Everybody know it well. So in the very beginning, we are discussing about diabetes first. Though actually we are not discussing the details of diabetes here. It is just a touch to you, and the things will be easier for you for further diabetes study in your learning materials and the books. So very challenging thing is diagnosis of diabetes. It is very important. And many of you actually couldn't raise your hand because you are confused. So diabetes is a very common disease. We should not be confused about the diagnosis. And in our practical experience, say that actually somewhere we are confused. We are treating some patients, actually they are not diabetic. I have seen in home and abroad as well. So we have to be very careful about the diagnosis of diabetes, because in the Western world, it is one of the bad news. Usually in our country setup, we ignore it, diabetes. But as a chronic long-term disease, it is very, very, very bad news. That means very sad news for a patient. So we have to be very cautious about the diagnosis. Now I am showing you the diagnostic markers for the diabetes. So there are many opinions from different authors, you know, that the leading one or two, rather to say, American Diabetic Association and World Health Organization also. And there are some nice guidelines also, you know, about. But we observe that there is almost no difference, only a little difference in the lower range of the fasting value. Even then, when we talk about the diagnostic cutoff value, all are same. So I collected it from American Diabetic Association. In the left side blue panel, you can see these are the criteria for the diagnosis of diabetes, and these are the pre-diabetes. That means when you diagnose this impaired glucose tolerance, this is one of the example of pre-diabetes. So fasting plasma glucose is high, but not crossing the diagnostic value. Or 2-hour plasma glucose after glucose drink, it is 11.0 millimolar. You have seen here, if it is not more than 11, but not less than 7.8 also in between. So this is impaired glucose tolerance. So in this situation, we term it as pre-diabetes because invariably this patient will be a diabetic patient later on. Anyway, if you come to the main panel of diagnosis of the diabetes, you see there are 4 types of sampling. One for the A1C, hemoglobin A1C, another fasting, another 2-hour after plasma glucose drink, and plasma glucose after the drink, and the random sample. How to utilize it? It is very important. I like to share with you my personal observation is the rule of 2 here. Whenever we come across a symptomatic patient, patients are symptomatic of the diabetes, high blood sugar. What does it mean? Polyuria, polydipsia, polyphagia, weight changes, weight loss or weight gain. Both can happen. These are very typical features of diabetes. If patient having this symptom, and if you go for a random blood sample, it should be more than 11.1, or rather to say 11, to make a round figure, more than 200 in the milligram per DL value. But if patient does not have any symptom, we have to go to get the help from the 3 options: A1C, fasting plasma glucose, and the 2-hour plasma glucose after the drink. So traditionally we were using these 2 before, fasting plasma and the postprandial one, that means after the glucose drink. In the last few years, 2010 or 12, I can remember in my study time of these MRCP. So at that time, this one clinically introduced, A1C. Previously, it was costly and there are some limitations of this. So now we are getting 3 separate weapons. From there, any 2 positive is the diagnostic of the diabetes, even there is no symptom. So remember this thing. But symptom is there, only one value is important, especially fasting plasma glucose. So which one is the valuable marker for the diagnosis? Rather to say fasting plasma glucose, the most important one. All are important. Not only one value can diagnose the disease. Without symptom, even plasma, fasting plasma is high, plasma value is high, glucose high. Even then, we have to go for the other one. So I like to summarize here. Any 2 should be positive. 2 investigations should be positive, or symptom plus 1 investigation. Then we can tell that patient having diabetes. So up to this, I think enough for understanding how to diagnose diabetes by the testing. As you don't have any raising hand, I am not seeing any raising hand, so I like to skip further, please. A little different thing, like to show you that in the female patient, pregnant lady, it is called gestational diabetes. So the values are little different. I'm not detailing here. You just make a snapshot and you will be given the PDF as well. A little difference is there. Please go through by yourself how to diagnose diabetes in a pregnant lady. It is called gestational diabetes. So these are another many descriptions are there. Just to put some information from here that hemoglobin A1C have some limitations. Some limitations possibly I have shown in the previous slide also. So this is up to this diabetes diagnosis. Now come to the second question, please. Please go through, and anyone please raise your hand. Please everybody be cautious to be interactive with me, not be silent. Your answer may not be right. Don't worry for that. You just raise your hand and come into the discussion. And I'm drawing your kind attention that in few questions, we try to design in a manner that this is the presentation in the history. The second bullet point is the examination finding. The third one, the investigation. Traditionally, this is the way of patient evaluation: history, examination, investigation. So be attentive to all of three. Somewhere three stems are not there, but in this question, these are available. Utilize this technique, please. But be actually free also. Feel free to ask me if you don't understand the question even. Don't be silent. After 1 minute, usually the slide will be over. In the meantime, you just make an answer in your mind. Nobody is raising the hand. So giving some clue. Some clues are there. Now can you select your answer? Don't be afraid of nice guideline. Nice guideline according to we are practicing now also. There is not very absurd one. Dr. Arifin, please.
So, glibenclamide
You are selecting glibenclamide
or
or
pioglitazone.
No,
Or
no.
pioglitazone, sir.
Please select only one. This is the best of 5
yes.
format, not 2. Okay.
Have you fixed? Yes, okay.
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 Dr. Beg, please.
Pioglitazone, sir.
Pioglitazone. Okay, Dr. Beg, please.
Yeah, thank you, sir. As much as I know that the NICE guidelines suggest pioglitazone in this aspect, if the patient is obese and they're having insulin resistance, probably this patient is having insulin resistance.
Actually, answer will be exenatide. Exenatide. In the obese patient you see BMI is 41. Body weight is very, very high. So the treatment we have to choose in a manner that it will lower the blood sugar as well as lower the body weight. The guideline just I like to show you now how you are selecting the exenatide. So these are some informations given to you, especially the BMI more than 35. It is very alarming. And in this picture, things will be very clear to you. This is NICE guidelines summary. You see, this is the exenatide panel in the lowermost part. If the patient's duration of illness is less than 10 years, we can choose exenatide. If obese and usually less than 10 years, it means that, again, this exenatide will act on the pancreas and it will have the release of insulin from the gland. So within 10 years, it is expected that there will be some store of insulin in the pancreas. So within 10 years, patient presented to us, if we give more attention to minimize the weight, the drug of choice will be exenatide. Exenatide. This is usually injectable one. You can choose other drug also, but the number one and always number one drug is metformin. You have to start with the metformin and then you can choose other alternative drugs. So there are two panels are there, especially these are the pink color, that to say this is the first line choice, and the second line is a different color. If sometime patient is intolerant to metformin or metformin cannot be given for some other reason, then we will be starting with sulfonylureas. So many things actually are to be concerned or to be understood when a guideline is set. And for our MRCP exam, we have to follow the guidelines. Sometimes our honorable teachers, consultants are utilizing their personal understanding for some exceptional critical situations. When you look at them, you might be confused. If you are confused, you have every right to ask your teacher with due respect that, sir, why you are doing this? I don't understand. Can you let me know? But don't be confused. You have to follow the guidelines, especially NICE guidelines for most of the diseases for MRCP exam. These are not beyond our traditional practice. It is also true. Very exceptionally, some teachers or consultants thinking a little differently for case by case issue, not for general patient. Okay. So if you have any query up to these also, you can raise your hand in the meantime regarding the choice of the drug. If you have, I'm going back also in this question. Please, everyone, feel free to ask about this. It's a very common disease. We must know about that. Do you have any question? Can you raise your hand? I think you understood well. Yes, you understood well. Dr. Beg, please. Any comment?
Thank you, sir. Is exenatide going to help to reduce the weight or the BMI?
Yes, definitely. It is proved. It is proved. It is proved.
Is there any cutoff value, like how many BMI should be reduced within what period of time? Like within 6 months, one.
You see, I've seen the BMI more than 35. If more than 35, you have to choose exenatide. It is not very strict cutoff value. It is only just understanding. They have written in such that where weight is of particular concern, that means BMI is more than 35, exenatide may be considered. So I explained you before also, consideration doesn't mean enforcing or making invariable to be utilized. Just you can understand, you can think yourself to utilize these exenatide if BMI is more than 35. Understood now, Dr. Beck?
Yes, sir.
Okay. Dr. Russell Al Mamun, please. Your question?
Sir, I'm hearing about this drug first time, so
No
I didn't
problem.
understand.
No problem. You just go
Exenatide.
through exenatide. Is a new drug. If you go through the book, already I have shown these slides from the book. Possibly you couldn't look at well because this is our process of learning. Just overviewing only. Step by step, we have to understand. This is very basic, right? So this is one type of injectable medicine utilized in the diabetes. If you go through the exenatide in your learning bundle, you will understand. And we will be with you. Don't worry. If you don't understand, you just ask us. We will try our best to help you.
Sir, in this slide where মানে exenatide স্যার মানে কোনটার মধ্যে পড়ে স্যার ইনসুলিন GLP-1 agonist খুঁজে পাচ্ছি না তো স্যার
In the lower part, you see I am moving the cursor.
জি স্যার
Lowermost corner here. Injectable.
Okay, sir.
Injectable. So actually,
Okay,
it is a very later part, not usually selected. Only the obese patient. You have to start with the metformin first. You see arrow down, step down, one by one.
Yes, sir.
First drug,
Yes, sir.
second drug, third drug. But for the obese, especially more than 35 BMI, you can choose. Suppose you can give insulin and exenatide both. No problem. But thing is that better to choose in the obese patient because insulin have some anabolic impact. It can again increase the body weight. So in this situation, the endogenous insulin to be released by the stimulating effect of the other drugs, and it will reduce the weight also. This is the glamour of GLP-1 agonist drug, and costly. For that you have not seen as a junior doctor, possibly you couldn't see. We are not practicing this drug in our journal or the specialist practice also. Very costly till now. Okay, thank you, Dr. Maman, for your question. Okay, coming to the next question, please. Try to understand and give your answer, please.
What's your older man with type 1 diabetes?
Please read silently. If you want answer, then raise your hand, please. Yes, Dr. Farhad is ready. Any other guy, please? My beloved colleagues. I like to hear from the new one who couldn't tell till now. And you shouldn't feel shy, please. Dr. Russell Mamun wants to answer. Welcome, Dr. Russell. What could be your answer?
Intraretinal microvascular abnormalities.
IRMA in short, right? IRMA. So you are planning for urgent referral to the ophthalmologist if patient develop IRMA. Okay, Dr. Farhad, please.
Sir, maculopathy.
Maculopathy. That means there are changes in the macula, very sensitive area, you mean, right?
hard exudate in the macular region.
Dr. Beg, please.
So thank you, sir. Probably any pathology in the macular region
Macular
is requires
region.
urgent.
Okay, okay. So macula is a very sensitive area. If macula is in problem, it needs urgent referral to ophthalmologist. IRMA in the staging of the actually what we say that pre-proliferative retinopathy, these are separate things. But macula is not actually a part of that sequence. Macula is separate pathology. Anytime in the initial part of the diabetes also, patient might have maculopathy. So maculopathy is very dangerous for the vision, and the patient may lose the vision. For that, if endoscopy done as a clinician or whatever person, doctor do the fundoscopy, if we find that there is a problem in the macula, there are different types of macular problem, immediately we have to refer the case to the ophthalmologist. So thank you, Dr. Mamun, as a beginner, that you have responded well. So this is a learning time, don't worry. One by one you will learn. So just I like to show you some pictures from the diabetic retinopathy. So Dr. Mamun very nicely uttered here that IRMA, sometime new vascularization elsewhere. It is called elsewhere. NVE, this is NVD. Just to remember, normal vaginal delivery. That means new vascularization near the disc, new vascularization elsewhere. So this is new vascularization. There are different types of IRMA pathology, but one may be that new vessels far away from the disc also. But not it is only one thing that this is the IRMA. So any new vascularization, this is very advanced stage of the diabetes, and it is called the proliferative retinopathy. This needs also referral. This needs also referral. But this depends upon the duration, staging, pre-proliferative, proliferative. But maculopathy can happen anywhere. So where is the macula? It is just in this picture, in the center, you see the dark area. This is the macular area. This is the arterial arcade. You see there is some exudates. So there is the maculopathy. There is maculopathy. So in this maculopathy, better to refer the case to ophthalmologist. So there are different phases of the diabetic retinopathy, and the last one is the iatrogenic. This is the laser photocoagulation scars. If you wish, you can make a snapshot of this picture as well. So up to this only diabetic retinopathy. In the part 1 exam, you are not facing such pictures, but the description of the pictures you have to face like this. And the question is very simple. If you know, you can answer. You can answer. Okay, good. So again, some extra features from diabetic retinopathy. This is very, very severe, rather to say, in the very advanced stage, fibroproliferation in the retina. So like the neovascularization, after the neovascularization, retina usually proliferate in their fibrous tissue. So fibroproliferation, you know that there is a pulling, sometimes there is a chance of bleeding. It's a very advanced stage. The retina sometimes become most white. So it is called white retina. White means in the differences less vascular also, but in the fibrous tissue also, many fibrous tissues are there, and it produces white retina. It is very advanced stage. It is called fibroproliferation in the disc, fibroproliferation elsewhere. So you see that there is the disc, optic disc, and this is a little away from the disc. This is also the diabetic retinopathy in very advanced stage. Okay. Thank you very much. Now come to the next question, please. Please go through again 1 minute. As early as possible, you can raise your hand. So everybody get ready to be asked. Don't be silent, please. So this is one of the emergency situation for the diabetes. Those who managed a patient of such in your previous life, it is easier for you to understand, to give the answer. No one ready? Bicarbonate 23, multiple medications patient is taking, hypertension, obesity, and sodium 149, glucose 42. So very, very high glucose, sodium also high. 72 years old man, diabetic patient collapse. What could be the reason? There are two emergency, right? Diabetic ketoacidosis and HHS. HHS means hyperosmolar hyperglycemic state. So which the state and how to treat, from there you can answer here. So I think Dr. Beg is willing to answer, please.
Thank you, sir. Right. I think the picture shown here and the investigation probably is a case of HHS.
Okay.
The sodium is high, also the potassium.
And what will be
So-
the rate of glucose lowering down in this situation? If it is HHS.
I think, sir, we should not be so slow, not at the same time should be so quick. So I would like to go in the middle.
So what will be the
Probably
middle one?
Right.
This is the answer.
Having the C, sir.
3. This is 3. Okay, not more than 5. Not more than 5. Not more than 5. Okay, so we have to identify this is HHS, hyperosmolar hyperglycemic state, and not diabetic ketoacidosis. And usually in the diabetic ketoacidosis, the target of glucose lowering rate is 5 millimole per hour. 5 millimole per hour. But in the HHS, it should be less than the 5 millimole per hour. This is a very small question, but background is important to be understood. The previous term is the HONK, hyperosmolar non-ketotic coma, but the recent terminology is HHS. So the description is there. In the HHS, the patients are very sensitive to insulin. Usually remain sensitive to insulin. So if you give the lower dose of insulin, drastically patient, even the glucose level will be lower. So lower means a little higher, rather to say. But in the diabetic ketoacidosis, this disease is due to deficiency of the insulin. For that, we can give a higher dose of insulin. And in the diabetic ketoacidosis, we are tackling glucose as well as we are tackling ketoacidosis, both together. For that, in the diabetic ketoacidosis, we have to utilize insulin a further away. When blood glucose under control, even then, we have to extend the insulin therapy also. So please you write down in your note, this extended insulin is called extended insulin regime, especially in the diabetic ketoacidosis. But it is not needed in the HHS, the patient described here. Please, my beloved colleagues, if you have any query, you can raise your hand quickly. From this question, these are the discussion and the answer as well. No more? Okay. So, in these 4 questions, the very, very important topics of diabetes, we tried our best to cover. Diagnosis, some treatment, some emergency situations. So these are very basics in the diabetic patients. So now you are advised and encouraged also to go through the questions bundle with you about the diabetes. In coming other questions also, there may be some related issues of the diabetes, no doubt, or the related with the sugars. But these are very basic things we tried our best to discuss with you. Till now, if you have any query in your mind, please raise your hand. Please raise your hand. No more. If you understood everything, we are very happy. That's great. Okay. So I think, yes. Thank you, Dr. Mamun, please. Your question?
Sir, I have forget the difference between diabetic ketoacidosis and hyperosmolar non-ketotic coma.
Okay. Thank you very much. Just look at, actually, this is not the difference of the 2 diseases, only the clinical scenario of a patient of HHS is given here. So this is the way of learning. We are learning the patient, not the book. This is the philosophy of our study. So it's usually elderly patient of type 2 diabetes. And this is the most common diabetes. Around 90-95% patient having type 2 diabetes in the world. So whenever patient having very, very high blood sugar in this type of patient, the problem mainly will be due to fluid loss. Okay, you see the blood sugar is 42. So patient will be having heavy diuresis through the urine. So patient will lose many fluids. So there is hemoconcentration. Sodium concentration will be high. And there is many problems, not only the sugar. Especially in the HHS, there is a problem of hyperosmolarity. There is a chance of thrombosis in the vessels also. Many things are there. So you have to go through detail about the HHS. The difference is that diabetic ketoacidosis, there is high sugar, there is ketone body, there is acidosis. It is due to lack of insulin. But it is not for the lack of insulin. It is for maybe other reason. Patient is not following lifestyle, patient is not taking the medicine. Many reasons are there. But in the diabetic ketoacidosis, patient might have transiently also high demand of insulin, especially patients suffer from acute illness. Suddenly, patient insulin requirement will be high. Usually type 1 diabetes happen in the younger patient from the childhood, and the elderly patient will have type 2 diabetes. This is very usual. And in the type 2 diabetes, my beloved colleagues also remember that patient may have type 1 the diabetic ketoacidosis for a while, because in the acute illness, suddenly patient insulin requirement could be high. If it is not covered by the insulin, patient may go into diabetic ketoacidosis for a while. We have to think of this also. In the natural course of the disease, in the type 2 diabetes, once upon a time, all the insulin store will be finished. Whatever giving we are that the secretagogue, that means the sulfonylureas and other drug, it will not act, because this drug will act on the insulin to secrete, act on the pancreas and to secrete insulin. But insulin, pancreas does not have insulin in the later age of the life of a patient of diabetes type 2. In the later part, patient again may become insulin dependent. For in the previous terminology, those who are much senior, you know that there were terminology of non-insulin dependent diabetes, insulin dependent diabetes. Now terminology changed, that type 1 diabetes, type 2 diabetes. So type 2 become insulin dependent in the later life. Dr. Mamun, any query in your mind? Sorry, you muted by yourself. Dr. Mamun? Any query in your mind? I think no. Thank you. So we are going to the next part of today's discussion. Okay. There will be session 1B. Question number 5, please go through and raise your hand. This is another issue. What is the issue? You understand now. The low glucose issue, and what is the reason of the low glucose? This is the question. Some clues are given to you. Please, I want to see more raising hand, not only one. Only one only. Okay, Dr. Farhad, please welcome.
Sir, here's hypoglycemia with high insulin, but C-peptide is undetectable.
So, what is the reason?
So it can be the exogenous insulin administration.
Exogenous. C-peptide is undetectable, so exogenous insulin. Okay, serum insulin is high. It is causing hypoglycemia. Okay, thank you, Dr. Farhad. Now we'd like to hear from Dr. Dijpal.
Yes, sir. It seems to be exogenous insulin administration, and the C
Okay,
peptides are undetectable.
Dr. Beg. Okay, Dr. Vishpal, thank you. Dr. Beg.
Yes, thank you, sir. I think I also agree with the same answer. This is
Same.
due to exogenous insulin administration. But if there was sulfonylurea induced, probably the C peptide would have been raised.
Yes, it is expected.
Also.
You are right. Anyway, Dr. Saiful Arifin, please, your opinion.
Sir, insulinoma, sir. It may be a insulinoma.
If it is insulinoma, there will be C peptide also high because the natural insulin coming from the pancreas. The same happened to the
Yes, sir.
sulfonylurea also. So insulin will not be. This is the exogenous insulin administration. This is the correct answer. These are the description to you how to proceed on hypoglycemia. Okay. And just to add you, when we go through the hypoglycemia patient, spontaneous hypoglycemia, what are the common reasons? Could be that sulfonylurea, could be that insulin exogenous. If it is sulfonylurea stimulate the insulin secretion from the gland. So in the sulfonylurea, patient will be hypoglycemic, but patient will have high C peptide. Clear, Dr. Arifin? Can you hear me? Dr. Arifin?
Yes, sir.
Okay. If we give insulin from outside, so actually it will suppress the secretion of the insulin from the pancreas rather. So exogenous insulin cause the low glucose, but there will be no accompanied C peptide high. Okay. Again, if you give you commented the sulfonylurea, it is endogenous insulin coming from the cells of the pancreas, islets of Langerhans. So it creates the insulin as well as C peptide. I think things are clear to you. Okay.
Yes, sir.
Right. So I think be muted altogether. We are coming to the next one. Okay, now the question number 6. Please go through. Please raise your hand. Dr. Dijpal, please.
Sir, this woman might be having the pheochromocytoma. She's
1 year
having sympathetic
history.
stimulation.
Okay, sympathetic
Intermittent sweating
stimulation.
with
Sweating is there, but what about the weight gain? What about the weight gain, Dr. Dijpal? Okay, I prefer to ask Dr. Russell Mamun, our new colleague today. Dr. Russell Mamun, please, can you answer?
This may be hypothyroidism.
Hypothyroidism explained by the weight gain, but about the sweating, Dr. Mamun? Hypothyroid rather cold. How
Oh.
can they sweat? So you are the same problem of Dr. Dijpal. Okay. But I appreciate you. You tried your best. Dr. Arifin, please.
Same as because, sir, the age is an issue, sir, over here.
Okay, then?
Being a female, menopause area, around menopause time, there may be a thyroid issue.
Thyroid. Weight gain can be explained, but sweating, 45 years, you are meaning that post-menopausal lady.
Yes.
Could be.
Around,
Could be. It's very exceptional one.
it could be, sir.
I can remember one case also. Anyway, but it is not usual that patient will have sweating in the hypothyroid patient. Okay. There may be some additional issues could be there. Only hypothyroid cannot cause sweating. This is the thing. But one answer should be very clear that which can cause both together. This should be the correct answer. Dr. Farhad, please.
Insulinoma is the answer, as because insulinoma causes intermittent sweating, hypoglycemia, and patient used to take more food, more carbohydrate, and it causes weight gain.
Yes, thank you, Dr. Farhad, your explanation. I think this is acceptable. Dr. Beg, any opinion from you now further?
No, so thank you. The answer is given correctly,
Yes,
I think,
yes.
and well explained.
Well explained. So it's a very small question, how tricky it is. This is MRCP exam. This is the insulinoma. So we know that in the neoplastic disorder, patient actually lose weight. But exceptionally in the endocrine neoplastic disease, in some diseases, patient gain the weight. This is one of that. Another one, Dr. Beg, can you tell? Weight gain, but patient having tumor. Cushing disease, isn't it? Endocrine
Cushing
tumor,
disease, right, sir?
Cushing disease. So many endocrine diseases are there. Patient actually gaining weight, but this is neoplastic disease. Patient needs surgery also sometimes. So endocrinology is very interesting. Good. Thank you for all of you for your participation. And this is the explanation again as before. Insulinoma we discussed before. And regarding the hypoglycemic state, I like to tell you, to inform you that to confirm the hypoglycemia actually not mentioned in this algorithm well, in a manner that clinically it is called Whipple's trial. Patient will have hypoglycemia in the blood, will have the symptoms of hypoglycemia, and it should be overcome by giving the glucose drink or by the glucose introduction to the body. So if the three features are satisfied, then we call it Whipple's triad. Then we can suspect this is hypoglycemia, because under the hypoglycemia, there are some dangerous diseases you understand, like insulinoma. Patient may be due to some other insulin injection or the sulfonylurea. So in the history is very easily will tell us about the insulin patient taking or not. But there are some what I say, the factitious issues also. Some health personnel also will not give the history. Intentionally they are taking the sulfonylurea and the insulin injection. So at that time we are confused as a doctor. So we have to go for this test. But to confirm the hypoglycemia, we have to go for a prolonged fasting test. Please write down in your book, prolonged fasting test. This word is enough for you. Please you go through by yourself how prolonged fasting test is done. Then, if the prolonged fasting test is positive, better then go for the further investigations. This is the method. But sometime in our real practice, we are bypassing this thing and going directly to this test after correlation with other features. This is exceptional. But method is go for the prolonged fasting test, then go for the other test. Or you can do all together in the practical situation. Question number 7. Please go through. Nobody is ready to answer. Someone writing on the end. Okay. Which will given the answer. Dr. Maksuda, welcome now. Yes, Dr. Maksuda, please, what is your answer?
Thank you, sir. Understanding the scenario, he is a patient of 58 years. He is 58 years old with a long-term diabetic patient with neuropathy, peripheral neuropathy.
Yeah.
So he is managing his diabetes by taking oral hypoglycemic drugs. Along with that, we have to give him some drug for his peripheral neuropathy.
What will be the drug of choice here? This is the question. What is the drug of choice here?
Yes, sir. So I would like to go with gabapentin.
Gabapentin. E. Dr. Beg, please, your opinion.
Yes, sir.
Dr. Beg.
Yeah, thank you, sir. I think also I would also go for the same answer.
Gabapentin. Okay, many options will be
neuropathy.
there. Many practicing doctors will tell something different also. Dr. Farhad.
Sir, in that scenario, carbamazepine make the
Carbamazepine,
best choice.
all are utilized for the neuropathy. Even the axocin cream also, capsicum. Maybe, right? Dr. Farhad?
Yes, sir. Yes, sir.
Let us see which is the correct answer. Why Dr. Saiful is not telling anything? Dr. Saiful, what is your opinion? Dr. Saiful Islam. Can you hear Dr. Saiful? Cannot be.
Yes, sir.
What is your answer? Saiful, quickly, please.
Carbamazepine, sir.
Carbamazepine. Sorry for everyone. This is the guideline, and more efficacious drug will be duloxetine, SSRI. Very exceptional one, try to remember. Duloxetine, drug of choice of diabetic neuropathy in diabetes. You can utilize many other drugs, no problem. If duloxetine patient have the side effect, other things. But it's very recognized drug, duloxetine, SSRI. Okay. Unfortunately, all of your answers are wrong. Anyway, question next one. Very small question. MODY, M-O-D-Y. Please quickly raise your hand. Possibly you know or you don't know. All or none know. Dr. Beg, please.
Thank you, sir. Well, it's a genetic disease probably, and the glucokinase mutations causes this MODY probably. Sir.
MODY, okay, glucokinase mutations. Maybe the answer. But what about the MODY? Maturity onset means usually type 2 diabetes. But it is happening in the young. That means the young patient become bulky, obese. This is MODY. There is a reverse also, I will tell you later. Okay, Dr. Maksuda, I think, willing to tell something. Hello. Sorry, Dr. Maksuda, do you like to tell anything?
Sir, I think this could, I'm not sure, but I think this could be leptin mutation.
Leptin mutation. You should not be sure why you are worried about sure or not. You just try your best.
Yes, sir.
We're the learning session. In the other participant, my beloved colleagues, please always be in interaction. Don't feel shy. So I'm telling about the maturity onset. It's the exceptional one. Okay. So maturity onset diabetes, there are some genetic issues, and just to remember, otherwise you cannot answer. These are glucokinase mutations, and overall, overall the MODY is as like in the book. There is a box you can go through. Okay, MODY 1, MODY 3, MODY 5, MODY 2, different types of MODYs, and some MODY are not much dangerous also. Okay, so these are the informations. You can just make a snapshot. There is nothing more technical thing. You just know something about MODY. Very small information. And we observe that MODY is an important topic in MRCP. Many often it was appearing in the exam. Remember it. So I will repeat the word for you. MODY, maturity onset diabetes in the young. But what about, you see, in the lowest panel now I added LADA, latent autoimmune diabetes in adult. So this is a reverse thing. Usually type 1 diabetes is autoimmune diabetes, antibody mediated diabetes. So it's a type 1. So type 1 usually happen in the early age, childhood. But few occasions, some patient may develop type 1 diabetes. That means insulin dependent diabetes in a later ages. Later doesn't mean 60, 70 years. It is around 25 to 30 years like that. In this age, patient detected as high glucose, oral tablet cannot control. A little control there, but after a few months, it is beyond control. In this time, patient definitely need insulin. And usually patient will be lean and thin, not bulky. For that, it is latent autoimmune diabetes in adults. So there is reverse thing, MODY and LADA. MODY and LADA. Please write down.